Class 2021, welcome. My name is Dr. Compton, and I'm here today to talk to you about COVID-19 and contact lenses. This is my first time with this conference, and I'm super excited, especially in this format. It's actually completely different, which kind of goes to what we're going to be talking about today, in that how much COVID or coronavirus has actually changed the world that we live in. We look at this image right here. This is the severe acute respiratory syndrome, coronavirus 2, as we know, COVID-19. This is actually an electron micrograph of a cell that's heavily infected with the coronavirus. And what we're going to do is we're going to dive in really deeply, kind of understand what's happening here and how there was a direct correlation of what happened to how we've modified it, how we do things, especially with contact lenses. Now, when we think about the contact lens industry, so much came out this time last year with regards to information on how to run our practices, information on how to wear contact lenses, information on how to keep ourselves safe, how to keep our patients safe. And we were just completely bombarded with all that information. And today what we're going to do is we're really going to kind of fine tune that information and make sure that we're all moving in the same direction with how we instruct ourselves as patients and our staff. But before we start, I want to be very clear. I'm not a virologist. I'm not an epidemiologist. But like many of you that are out there listening to this lecture today, I was a practitioner that was forced to become extremely knowledgeable on this topic because it affected my patients, it affected my family, it affected my practice, and people were coming to me, as I'm sure they were coming to you, for answers. And that's why I think it's very important that we have a very good, concise understanding of what we're dealing with. So just a little background. My name is Dr. Compton, as I explained. I have work experience in that I own 2 private practices, one in Manhattan and one in the Bronx. I am on staff at SUNY Optometry, where I'm an assistant adjunct professor. And I also teach at Renaissance Technical Institute. It's a school where we teach people to become ophthalmic technicians. As far as my training is concerned, I graduated from SUNY, State College of Optometry, and I did my residency at a VA medical center in Wilmington, Delaware. Now, at this point in my career, I have a lot of professional affiliations, which we'll kind of go into a little bit deeper in today's lecture and the connection with coronavirus. But I hold a regional trustee position for the New York State Optometric Association. I hold several positions within the American Optometric Association, namely the chair of the contact lens and corneal section, and there's some other affiliations there. But as we talk about those connections, there are 2 that I really want you guys to have a very good understanding on, because they had a huge impact on how I practice today with regards to how coronavirus has affected the contact lens industry, that being the American Optometric Association and the NYSOA. So many of you maybe to date have seen this image. This is an image that's on a lot of commercial material that talks about coronavirus. So what I want to do is we're going to actually dive into this image. What are the things that are in this image, and like why this kind of caricature has been so popular in our understanding. Now, when we're going to talk about viruses, we need to kind of take a step back and look at all types of pathogens. All viruses are parasites, but the thing is they can only reproduce within cells. We talk about other pathogens like bacteria and fungi. These things are self-reproducing. These things can reproduce themselves in soil and water, on inanimate objects, sewage, within other organisms. They can be in all different places. But viruses are very specific in that they have to have another host to work with. And now, when you think about how viruses function, a virus comes in contact with the host cell, and this virus, what it needs to do, it needs to inject its genetic material, or we call the genome, into that host. Once it does that, the whole object, or the whole idea, is that this virus needs to take over that host cell's function. Once infected, this host cell, the cell that the virus just injected into, now is doing something completely different. It's actually starting to recreate that virus. This is what's kind of depicted here in this image, where we see the virus, it's attaching to the host cell. Once it penetrates that host cell, it's able to inject what we say the cytoplasmic viral genome, and that's the RNA or the DNA. That's the makeup, or that's what's convincing the host cell to now do something differently. Now, I mentioned DNA and RNA viruses. They're basically 2 types of ways that we classify them. And as I said, that's how we understand the genetic material. They're either RNA or DNA. Now, there are so many different types. They vary, as we said, RNA, DNA. They vary as being linear or circular. They vary in length, the number of molecules. And as you can see here, I have listed some of the common virus families that exist that we may be familiar with. We look at the DNA viruses, the adenoviridae, that's what we know is the common cold. You look at the herpes viridae, we're familiar with things like simplex, zoster, cytomegalo, Epstein-Barr. We talk about the poxviridae, that's when we talk about smallpox. Now we slide over to the RNA. There may be some names that you are familiar with as well, like the picovirinae. That's your rhinovirus or polio. You know, we talk about the flaviviridae. Excuse me, that's dengue, hepatitis, yellow fever, Zika. Orthomoxiviridae, that's your influenza viruses. Paramoxiviridae, that's your measles, your mump viruses. Raboviridae, that's where we talk about rabies. Then you have Ebola, and today we're going to dive into the coronaviridae. Hepaviridae, that's your hepatitis. So as you can see, there's so many different viruses, but they're easily categorized when we do it by RNA versus DNA and their virus structure. And that's kind of what I want to talk to for a second. Now, when a virus isn't interacting with a host cell, it has to be protected. And what it does, it has what they call a protein shell, or in other words, a capsid that protects that RNA or that DNA genome. Here you have pictures of these different types of protein shells, whether helical, polyhedral, spherical, complex. But basically, the idea is that RNA or DNA is inside this envelope, this protein shell, this capsid, in order to protect it. Now, when we have that basic understanding of the structure of a virus, it helps us understand why coronaviruses are so strong, or as I should say, SARS coronavirus 2 was so strong. This is a drawing of how helps us understand the structure of the coronavirus. So the coronavirus, these are RNA viruses that we talked about in the previous slide. They're tightly packed and surrounded by a protective protein shell. That's what we call the capsid. So the capsid is that kind of reddish area, and the RNA is that line that's kind of running through it. Now, this protein material, this capsid, is really serving as the first line of defense for the virus, for that coronavirus, around its environment. Now, it's not only protected by that protein or that capsid. Coronavirus 2 actually has a second line of defense, and that's the outer membrane. And we call that the envelope, and it has all types of lipids and proteins that, again, help protect that RNA. So now these membranes are modified into specific viral proteins. We call them the S, which are the spikes, the M, which is the membranes, and the E, which is the envelopes. When you look at the picture, you can see the spikes are those little yellow things that are protruding outside of the envelope, and and that is what kind of helps create this whole protection mechanism. And that's really what the picture is depicting. Those S proteins that are coming out in red, that's where the whole idea came from, and that's what a coronavirus looks like. So coronavirus and functioning, we talked about how viruses function. What viruses do, the virus comes to the host cell. Once it attaches to the host cell, it enables or it forces that host cell to do things differently, do things that the virus want them to do. So now, when it comes to coronaviruses, primarily they infect humans, and they affect humans in the lung. And that's why it's called the severe acute respiratory syndrome. But very specifically in the lung, it attaches to an enzyme called angiotensin converting enzyme 2. So basically, once corona is introduced into your lungs, it's looking to attach to that enzyme, okay? So once that virus sees that enzyme, okay, the virus spike protein attaches to it, okay? The virus is then incorporated into the cells, And the RNA is injected, as we discussed previously, it injects its genome into that host cell. So again, what does a virus do once it injects the host cell? It causes the host cell to act differently. So what is happening with coronavirus 2? The viral RNA gets in and it forces the host cell to start to reproduce the RNA. It's starting to reproduce, to synthesize hundreds of nucleocapsids, hundreds of membranes, envelopes, and these spike proteins. It's actually just forcing the host cell to create more coronavirus. Okay, the new virus cells are released out of the cell, and eventually the cell goes off and dies. And that's kind of the whole process of everything going. And that's kind of what's indicated in this cartoon image on the side. You can see how you have the virus. You can notice those spike proteins that are emerging out of it. And once they find the attachment, again, that ACE angiotensin converting enzyme, once they're attached, they're able to inject the RNA, and the RNA causes that host cell to reproduce more coronavirus. More coronavirus is released from the cell, and it just kind of propagates and continues in that fashion. Unfortunately, the cell's dying. You know, this is another kind of really zoomed in picture of what we're talking about. Remember, we talk about that corona, that spike protein. You can see an image of it here where it attaches to the ACE2 receptor. Now, when we talk about coronaviruses, this is nothing new. I mean, coronaviruses were identified, I think we found like in the 1960s. And there are large families of them, and we're going to dive into that specifically now. But the ones that you guys may be familiar with, even prior to 2020, was MERS, SARS, and obviously Corona, or I should say COVID-19. But they all are named Corona for those spike proteins. Again, that's depicted in this image. So let's talk a little bit about coronavirus, because we probably were first introduced to coronaviruses with COVID, but there are various forms of coronaviruses. And if we were to divide them in subgroups, we have the alpha, we have the beta, we have the gamma, and we have the delta. When it comes to the ones that really affect humans, it's really the alpha and the beta. You have the 229E, you have the NL63, OC43, HKU1, MERS, and then you have the severe acute respiratory syndrome coronavirus and severe acute respiratory syndrome coronavirus 2. So those are the two coronaviruses that we're aware of that affect humans. And when it comes to the common ones, it's the number ones in the beginning, the 229E, the NL63, OC43, and the HKU1. But what we tend to understand about coronaviruses is that they affect animals and they eventually evolve to human. And this is an image that depicts all of those coronaviruses that I mentioned, and just shows that they generally originate with bats or rodents, and then they go into other animals and they find their ways over to humans. Now, this understanding of where coronavirus, or I should say COVID, specifically COVID-19, came from is a very hot topic right now. As far as the natural reservoir, the natural place that we understand beta coronaviruses to come from are from bats and rodents. And in December 2019, COVID-19 was first identified in Wuhan, China. Now, this is a very sensitive topic because there's a lot of different perspectives on where coronavirus came from. The World Health Organization is really sticking to the zoonotic understanding, where it just came from animals and changed to humans. And the CDC has since made some changes with their perspective on the origins, and a lot of it has to do with some new revelations that are coming out about when it came and if it was something that was engineered in a lab. We're not going to get into that right now, but it's important to understand that the professional, or I should say the doctors, or say leaders throughout the world, are not really, there's not really a consensus, I'll put it that way. There's not a real consensus as to where does it come from, but that's something that I feel over the next few months to years, we're gonna have a much better understanding of. But regardless of that, we understand that this virus had a huge impact. This is the Johns Hopkins University data board that is updated on a daily basis with regards to deaths and people impacted by corona. This was just done at the time of this recording, and there were 3.5 million deaths globally. We talk about 170 million cases globally. This website is really good to kind of give you a real understanding of how we were impacted globally. In the US, at the top with 33 million cases and almost 600,000 deaths. And it kind of trickles down. We're hearing a lot about what's going on right now in India and countries like the UK and Italy, and how this has just had an immeasurable impact on all of us. And, you know, connecting it with this lecture, I really want to talk about the impact that it had on the health industry. You know, if you just think a year back from today, healthcare facilities were stretched to their limits. All care, I should say, not just eye care, all care needed to be focused only on COVID. And governments did made decisions to do things on limiting non-essential care. This was a personal point for me because we were in a situation here in New York where they were telling patients that eye care was not essential and that we should be deferring our patients. Now, this is something that's sensitive to us because we do realize that we have patients that say glaucoma or various other eye conditions that need constant follow-up, but they were encouraged not to be seen by practitioners. And this is something that the AOA, the organization I play an active role in, really try to focus messaging on, or help them focus their messaging on the importance of these types of exams. It was our understanding that if eye care professionals could do what they knew how to do best, it would actually minimize the impact on the overall wider healthcare system. If patients were going to an emergency room to address an eye problem, that was pulling a doctor away from, you know, helping possibly a COVID patient. So this was something that we helped kind of the U.S. government kind of navigate through and help them understand the importance of the exams and the care that we provided. And what it came down to, thankfully, it was a state-by-state decision eventually, where states were able to indicate whether eye care was something that could be provided on a comprehensive level. Our federal government moved forward in April 19th, and they came out with what they called the recommendations on reopening facilities that were geared to helping offices that provide non-emergent, non-COVID healthcare. So that was, again, assistance that we had in our practices to help us understand, and our patients to understand, the difference between essential, non-essential, and where eye care kind of fit into that whole discussion. And this is the first page of that report that was released. But in all fairness, this was new to everybody. It was new to our elected officials. It was new to medical professionals. It was new to the public. And everybody had their theory on how to best limit the chance of infection. And well-intentioned, but unfortunately, during this time, we saw a lot of misinformation and speculation that was being reported, and it left people unsure of how to protect themselves and their families. And specifically, what we want to address today is how that impacted the contact lens industry. I mean, there were statements out there that contact lenses were unsafe. There were statements that contact lens wearers were more at risk for developing COVID-19. There were statements that certain contact lens materials were more riskier than others. Even statements that contact lens wearers should stop contact lenses altogether immediately and just move on to spectacles. Now, part of that opposing view was some of the organizations that lead in eye care. You know, the American Academy of Ophthalmology was on record encouraging people to discontinue contact lenses and return to spectacles at this time. Now, for us, I should say, even like for me personally, like we understand where the origin of the misinformation came from. And it wasn't something that people had malice behind it. It was simple. I mean, the virus spreads through respiratory droplets, and it can also spread to people if they touch the virus and then they touch their mouth, their nose, or their eyes. So contact lens wearers actually touch their face, touch their eyes. So it was worthy of a discussion as to really should contact lens wearers stop wearing contacts in for risk of accepting or transmitting coronavirus. But it wasn't up to us to just think of things anecdotally. We owed our patients much more. We know that their patients, for both personal and clinical reasons, need to wear their contact lenses, and that required us to take a really deeper look into this. And that's what we're going to do today. We're going to take a real deep look into what the research shows with regards to coronavirus and contact lenses. And to start right off the bat, a PubMed search, even to this day, still finds no evidence that contact lens wearers are more likely to contract COVID-19 than spectacle wearers. Okay? This was an article that I really turned to during the pandemic. I want to say it was released, I should have this date, sometime around April or May during the pandemic. And it really took a research-based look or view at how COVID affected contact lenses. The article is titled "The COVID-19 Pandemic: Important Considerations for Contact Lens Practitioners." Excellent article, which a lot of the authors on this article, I'm sure, are familiar. You are familiar with. And we'll dive into the specifics of what they address in this article. But if there's an over or underlying theme, I would say there's really no evidence to suggest that an increased risk of contracting COVID-19 through contact lens wear compared to spectacles, and no scientific evidence that wearing prescription spectacles provides protection against COVID-19 or other viral transmission. Okay, so what does the literature say? So starting off with the first one, there are actually no findings that support concerns that healthy patients are more at risk for contracting COVID-19 than they are as contact lens wearers. This first journal that we're citing here is The Role of the Eye in Transmitting Human Coronavirus, What We Know and What We Don't Know. Basically, the point that they made is that the eye is rarely involved in human coronavirus infection, nor is it a preferred gateway for the entry of human coronaviruses to infect the respiratory tract. Very interesting information. The next article I have that's cited here, which was from an article titled "Assessing Viral Shedding and the Infectivity of Tears in Coronavirus Disease 2019 Patients." And basically the claim that they made here was that the results from this study suggested that the risk of SARS coronavirus 2 transmission through the tears is low. Now, about glasses, what does the literature say? There's no scientific evidence that wearing spectacles provides protections against SARS coronavirus 2 or other viral transmissions. This first quote is from the actual CDC in their website, where they were talking about eye protection and stuff that's actually recommended by OSHA versus personal eyeglasses. And they were very specific to say that personal eyeglasses are not considered adequate eye protection. The article that I cited earlier went as far as to say that their assumed protection, talking about glasses, is intermittent. And additionally, their increased frequency of putting on and removing spectacles actually adds the potential for the patient to be touching their face each time. So in one respect, it's actually saying that it actually may even be putting patients at a higher risk. And looking at a picture like this, you can kind of see why. And you can understand, eyeglass wearers still touch their faces. But what else does the literature say? We can go further and see that there's no evidence of the presence of coronavirus in the tears or conjunctival tissue of asymptomatic patients. And even in those with confirmed disease, the presence is very low. This article, Contact Lens Wear During the COVID-19, stated that to date, there have been no laboratory studies reported on the ability of coronavirus to adhere to a contact lens. And this article, again, the one that I cited earlier, went as far to say is binding of SARS coronavirus 2 to contact lenses from the ocular surface in asymptomatic wearers would be unlikely. So you can see by diving into the literature, we're getting a very good understanding of the risk factors for coronavirus, but more importantly, the risk factors, or I should say the connection, if any, between coronavirus and contact lenses. Let's go to solutions. To date, no evidence exists of the ability of current marketed contact lens solutions to disinfect SARS coronavirus 2. Now, this topic is actually interesting because most of the data that I was able to find, or the data that it's out there, doesn't talk specifically about coronavirus, but it talks about what we understand about solutions and viruses in general. For instance, this first article talked about viruses, or the HIV virus, the AIDS virus, and it showed that common commercial contact lens systems were actually capable of safely decontaminating HIV from contact lenses, which is good to know. Another one talked about adenovirus, where it said a recent paper showed that benzalkonium chloride, a common ophthalmic preservative that we're all familiar with, could actually slow or halt adenovirus. You know, we found another paper that kind of dove into the whole rub and rinse technique understanding, and that when patients did that, it was more effective at removing viruses in general. So you can see first, these three articles, while they're not addressing coronavirus specifically, they're giving us insight on variables that will actually we could translate into our understanding for coronavirus. And then the final one really kind of goes into what we understand, or how our modern contact lens solutions systems are created. They have most of them have a surfactant, and that given that SARS coronavirus 2, it has that lipid membrane that we talked about earlier, it is plausible that the use of that surfactant with a rub and rinse regimen, it's very possible that this action could be effective at killing the virus. But we really have to dive in a little bit more to be conclusive with that hypothesis. But going along with the literature, it makes sense. What else does the literature say? It speaks about how patients should also avoid touching their face, including their eyes, nose, mouth, with unwashed hands. The article listed here, hand hygiene is linked to microbial keratitis, not really talking about viruses, but it talked about the importance of hand washing, and that the lack or inadequate hand washing is a risk factor for contact-related microbial keratitis and inflammatory events. Again, not directly talking about viruses, but we can make the connection. Another article listed here spoke about the significance of hand hygiene from preventing and transmission of microorganisms and reducing the spread of infection. And it really went in to show how our understanding of that was just brought to a completely different level when we talk about how coronavirus has affected us globally. When we talk about soap and coronavirus, I really wanted to kind of dive into that, because disinfecting our hands with contact lens patients is completely different from other possible medical professionals that can use alcohol-based cleaners. We don't want to use those with contact lenses because, again, we don't want that alcohol or that substance to get into the matrix of the lens. So soap and water is the most effective thing for how we practice. And when you understand the discussion that we had a little bit earlier, talking about the capsid and the envelope virus, you can see how effective soap and hand washing is. We break down that lipid bilayer and the fact that, you know, you have the water-loving hydrophilic portion and the hydrophobic portion, and how a soap molecule is just that micelle, and the fact that that hydrophobic portion actually aligns very well with the lipid layer of the coronavirus. And when it aligns with it, it actually is a catalyst to break it apart. With rubbing and washing the hands, once that micelle or that hydrophobic and the hydrophilic portions are now attached to that virus, it's easy to break it up, and the hand washing and the water molecules push everything away. And that's how something as simple as soap and water can be extremely advantageous when it comes to talking about how to combat or get rid of this virus. So the best practice advice for contact lens wearers during COVID was really nothing out of the ordinary, nothing that we haven't been doing for decades with regards to cleaning hands. Washing your hands is always vital. And again, it just brought it to a completely different level as we have an increased understanding about coronavirus. So what it boils down to is this: as long as contact lens wearers are using correct hand hygiene techniques, they really should be limiting themselves from any type of virus transmission as with regards to what we're talking about on the ocular surface. So this is good. This is huge because when you look at the literature, there's really no evidence that contact lens wearers, if they do what they're supposed to be doing, are at higher risk for developing COVID-19. So it's important that we really review these these hand washing techniques with our patients. It's recommended 20 seconds. They rub under the running water using a clean, dry cloth when they're finished. These simple things can go a long way in helping or limiting our patients' risk for transmitting any type of virus. So we've went through a couple different pieces of literature, and what do we glean from all this information? Number one, there's no evidence to suggest that contact lens wearers who are asymptomatic should cease contact lens wear due to an increased risk of developing COVID-19. Number two, there's no evidence to suggest that wearing prescription spectacles provides added protection against coronavirus. Number three, there's no evidence to suggest that any form of contact lens material is more likely to enhance or reduce the risk of COVID-19 in the future or getting an infection in the future. So having this understanding was extremely important for us moving forward. And the organization that I am affiliated with, the Contact Lens and Cornea section of the AOA, we really use this information to help reinforce the guidance that we gave the CDC with regards to proper hygiene and how contact lenses, if patients are doing what they're supposed to be doing, is something that's safe. So our messaging must be correct. Patients are going to continue and will always continue to look to their primary eye health care physicians for accurate guidance, especially on something as serious as contact lenses, but with other things with regards to health and vision. And so for this reason, it was very important for organizations like the AOA, but even just kind of when it dials down to the doctors, that we are all on the same page, that we really want to reinforce that contact lenses are safe and effective forms of vision correction if they're used appropriately. So what is our messaging? It's about the hand hygiene. It's about multi-purpose solutions, not only using the multi-purpose solutions and the types, but also that rub and rinse cleaning, reusable lenses, the importance of daily cleaning of the cases and throwing out that case on a nice schedule. But if you look at what's listed here, all of these things will help patients reduce the risk of virus transmission. But is there anything here that's unique to 2020 or 2021? Nothing. Again, these are all principles that we've been preaching for decades with regards to contact lenses. And it's really important that we have our patients help our patients to understand that. When we talk about coronavirus, there was so much responsibility that is now placed upon the doctors. Again, specifically speaking about contact lenses, during that time period, our patients were required to shelter in place, and at times they needed to refill their prescriptions. So as doctors, we needed to make that judgment call. Are we okay with extending an expired prescription? At times, doctors needed to facilitate shipping or delivering lenses to patients. But basically, it was a proud time because many doctors did their utmost to kind of be there for their patients. On some level, it was actually necessary because patients were going to get their contact lenses by any means necessary. And by us going the extra mile, it discouraged patients from going to get non-prescribed alternatives from online retailers. So, we commend a lot of doctors for the hard work that they did during this time. But again, looking at that office and the changes that needed to be made, like our offices were now required to prioritize patients on urgency. At some times, in some places, we were required to reduce the capacity of the patients that were in the office until these capacity limitations were increased by local governments. Platforms like telehealth and virtual eye care expanded on completely different levels because it was something that gave us the opportunity to continue that conversation with our patients. So these platforms are even something that we use in our office today, something that we wouldn't even think about a couple years ago. But when it came to these protocols, fortunately here in the US, we had a lot of options. We had a lot of guidance. The CMS, the Center for Medicare, Medicaid Services, had its recommendations for reopening. The CDC had its recommendations for reopening. The U.S. Department of Labor, so the OSHA, they had different ways. They reevaluated things for us in order so that we can feel comfortable, our patients can feel comfortable in coming to our offices. And all these protocols were made available to us. These new protocols involve things about clinical, but not only clinical, non-clinical services that we were forced to implement. What our staffs were supposed to be doing in the offices and how responsibilities maybe have changed. When we talk about optimizing patient care, that had a lot to do with our scheduling and staggering visits and office hours. We learned all about social distancing protocols and how to position patients throughout the office so that we could limit the possibility of virus transmission. Preparing the office and clinical areas and dispensaries, if you have opticals, on cleaning and sanitizing. These are all different things with how we sterilized, what we sterilized, and different disinfectants that we were using. These are all different protocols that we were forced to start to understand and to implement. We were forced to establish longer time frames in between patients. Patients that came into the office, masks were mandated. Some practice even would have to lock the door or have patients call ahead to see if they could come for the appointment. And as you look at your own experiences of what this time last year brought, I'm sure you can relate to a lot of the different things that we're discussing, even when it comes to cleaning and shutting the office down and how to clean and when to clean. These are all different conversations that we are not new to us because we were forced to kind of learn a lot during this time. And I want, as we start to make another connection to the contact lens industry, take a step back and just remind everybody what was behind all these office protocols. We understand this to be a virus that travels through droplets, in the air, when patients cough, when patients sneeze or talk or sing. These droplets will travel into the mouth and the nose, and that's how the virus is spread. So one reason that we had so much trouble with this virus is because so many people were asymptomatic and spreading the virus. Normally you think about the flu, you get sick, you stay home, but people were out spreading the virus unintentionally, asymptomatic, and that really made for a very challenging environment to keep our offices safe. And we talk about the impact of airborne transmission. We learned so much about social distancing, but there was not really a clear or a consensus on this. If you look at the World Health Organization, they recommended 1 meter. The CDC recommended 6 feet. When we talk about the origin of the 6-foot social distancing, we can go back decades to scientific studies that talk about how viruses tend to travel anywhere from 3 to 6 feet. And when the CDC made its decision on the 6 feet, it wasn't on a specific coronavirus study. It was more probably out of abundance of caution. And as we said in the previous slide, there has been some differencing in opinions between national and international guidelines that are put out there. But again, we want to do a review of studies just kind of for we can have a better understanding for ourselves. And again, just like any other study with coronavirus or COVID-19, a lot of these studies are new and they're trying to look at things a different way because all of this is just new to all of us. This is a great study that I found. It was a retrospective study, and what it did, again, on the topic of airborne droplets and social distancing, it looked at if there was any differences in schools and those around the students that had different social distancing requirements of 3 feet versus 4 feet. This particular study concluded that lower physical social distancing could be adopted because they didn't find a big correlation between the 3 and the 6 feet. This article was one that could be seen on the CDC, and they didn't really address as much the distance of 6 feet as much as they addressed who should be social distancing, who should be within the social distancing, and at what phase of the virus, meaning people that have comorbidities or are at higher risk for having problems with the virus. Those are the people that really should be social distancing, should be practicing social distancing. But again, a literature review is how we want to help ourselves come to these types of conclusions. Now, when we talk about cleaning, human coronavirus can persist on inanimate surfaces, but can be efficiently inactivated by surface disinfection procedures. So what we've learned, what does the literature say? Basically, human coronaviruses can persist on inanimate surfaces, but can be efficiently inactivated by surface disinfection procedures. This issue is actually a very interesting one and something that's been changing. I would say even as recently as the last month or two, the CDC in the US currently maintains that the virus doesn't live on inanimate surfaces as long as we originally thought it did. Yes, it still can persist, but not that long. So this is actually new information, which is very helpful. But regardless, if it is, these articles, as they indicate, go a long way in helping us understand how to deal with that. You know, like the first one, it says, in addition to common soaps used in hand washing, the SARS coronavirus 2 is very likely susceptible to the same alcohol and bleach-based disinfectants that eye care practitioners commonly use to disinfect ophthalmic instruments and office furniture. So look at that, nothing new. Second article, to prevent SARS coronavirus 2 transmission, the same disinfection practices already used to prevent office-based spread of other viral pathogens are recommended before and after every patient encounter. So again, nothing new being presented. If we're doing what we've always done before, we have a very good chance of limiting virus transmission. So disinfecting the office, we understand that percentages of ethanol, hydrogen peroxide, sodium hypochlorite are very good at fighting viruses, specifically coronaviruses. Other biocidal agents such as benzalkonium chloride and diclonate are not as effective according to certain studies. But when it comes to using bleach, it's important that it's diluted. And if you use correct balance of solution, we can be very effective in fighting the virus in our offices. Some offices or some literature recommending purchasing a spray bottle and filling it with diluted hypochlorite, the bleach. We have 5 tablespoons, a third cup of bleach per gallon of water. So again, cleaning these surfaces with this kind of solution can go very far in preventing virus transmission. Now, when it comes to the equipment that we have in our offices, our contact lens equipment is extremely expensive. So you want to be careful and follow manufacturing recommendations with regards to how you clean. You know, we're talking about your autofractors, your topographers, your OCT. A lot of times they do recommend 70% alcohol, but you got to be careful that you don't damage it. And that's why you really want to lean on your manufacturers to ask them the best practices. With regard to our tonometer tips, in our office, we use the hydrogen peroxide solution balance You can use the bleach, but it's recommended that you really don't want to soak it more than 5 minutes to limit damage. The understanding when we look at the literature that says that COVID is deactivated by 70% alcohol, but it may not be as equally as effective against adenovirus like the common cold. So again, something more to take into consideration. And if your practice has opticals, you really want to be careful about using bleach or even alcohol-based products on the frames because it could damage it. So in our office, we use the peroxide combinations, but you want to contact the manufacturers, the specific manufacturers, and see what their recommendations are. See, it's just amazing how our office protocols have just changed substantially. We're now required to maintain supplies and stock of all this cleaning and sanitation material. Yes, we've done it before, but it's actually to a much greater level. We have to have this PPE or this personal protective equipment for our staff, for our non-clinical staff, for even patients that come into the office. And making sure that we have ample supply of these things is really going to be how patients will feel comfortable coming to our offices. And when it comes to staff training specific to PPE is very important. They have to be able to demonstrate that they can use it with some level of competency, because if you have the mask on and then you're touching your face with the gloves and stuff like that, that kind of defeats the purpose. And you really want your staff to be setting the example for patients that come in, and proper education of that staff will help us get to that point. When it comes to screening protocols, we know that we've all are doing things differently. This is a picture of the temperature screener that we have in my office. When patients come in, they are required to check their temperature. Now, we all know that it's not a great screen for the disease or for the virus, but it helps to kind of screen patients. The CDC defined that a fever anything over 100.4 is something that should be monitored, but it is one of the protocols that we've implemented in our office. In addition to that, when patients come in, you're asking them certain questions, whether the patient has been in close contact with someone that had a confirmed case of COVID. Do they have any respiratory, cough, shortness of breath? Had they had a fever? Any other symptoms related to COVID, like loss of taste or smell? Have they traveled? So these are all new questions that we're requiring our front desk to have with our patients before they come into the office to protect not only the patients, but the staff. And if there are any patients or staff have any signs of COVID, they should be contacting their PCP. And if there are any emergency signs of COVID, they need to seek medical attention immediately. And we talk about symptoms or signs of coronavirus, we're talking about coughing, fever, headaches, if they're tired unnecessarily, or chills, sweats. But the really big one is that difficulty breathing, because we know SARS stands for severe acute respiratory syndrome. This is something that will affect the respiratory system. And if anyone of the staff shows signs of being sick, they should not be permitted to work for fear of transmitting it to others. And the same that we encourage patients and other visitors that are in the office that they should seek either attention from their primary care doctor, or if it's an emergency, they should go that route to seek emergency assistance. Okay, so let's talk specifically about contact lens protocols and how we've changed things with regards to contact lenses in a coronavirus world, post-corona COVID-19. So when it comes to our scheduling, that has actually taken a hit. We have to reduce the length of time between patients in the office. We have to think about the numbers of patients in the office and the reception area. And when fitting contact lenses, social distancing concerns need to be respected. So there's all different types of concerns that we have, or new concerns that we have as we're dealing with coronavirus in our societies. And the way that I wanted to break this section down was really to break down the contact lens process. We have the fitting process, insertion and removal training, and follow-up care, and just talk about how we've done things in our offices and some examples of what other offices are doing to remain compliant and healthy. So when it comes to the contact lens fitting process of soft lenses, it's a little bit easier because honestly, in this category, we're using diagnostic lenses that are single use, and we discard them after every patient. But soft lenses aren't always that simple. I mean, there's all sorts of reusable soft lenses that now have an added concern of virus transmission. So we're talking about specialty soft lenses. This is an example of a patient that we do a lot of prosthetic lenses in our office. You're talking about cosmetic color lenses. So these are lenses that you may have diagnostic pairs in your office that patients have to reuse. So in these instances, what are we doing? The good news is, once again, we have protocols in place that allow us to put forth a safe environment for our patients. This right here, this infographic is one that our office actually implemented prior to COVID, and this was a disinfection protocol that was developed in cooperation with the American Optometric Association Contact Lens and Cornea Section and the American Academy of Optometry. And what it was a disinfection protocol that was based on the 2018 recommendations from the ISO, which is the International Organization for Standardization. So what it did here was it created a process that was recommended that we implement after every use of reusable contact lenses and after every 28 days if lenses have been opened and not reused, so that they can be subsequently disinfected and create, again, a healthy environment. As far as the gas permeable lenses are concerned, we talked about placing 3% hydrogen peroxide with the GP lens in a non-neutralizing lens case. We disinfect the lens for 3 hours, and then they rinse the GP lens with a multi-purpose solution. As far as hybrids and soft lenses, we followed a little bit of a different protocol where you're placing 3% hydrogen peroxide with the soft or hybrid lens in that non-neutralizing case for about 3 hours. After that, then you transfer the soft lens into a neutralizing case, fill it with that 3% hydrogen peroxide, and add that neutralizing disc that we're familiar with, the one that bubbles up. But you want to follow the manufacturer's recommendations for that. You neutralize the lens for 6+ hours, again, following the manufacturer's recommendation, and then you're going to rinse the lens with multi-purpose solution. So again, we have an opportunity where it's really nothing new. If we're following the practices that we did pre-COVID, we can still be compliant in a COVID-19 contact lens world. But the truth of the matter is, ultimately, we want to do our best to limit the number of times we're touching the patients, because there is a lot of touching with regards to contact lens fits in the office. And the only way to really do that is really by minimizing those diagnostic, those reusable lenses. And the best, or should say the next best alternative, is our empirical fitting options. Now, GP lens empirical fitting has been around for quite some time. I mean, those that use this in their office know how easy it is. I mean, you provide a fitting consultant your Ks, you provide your refraction, you provide your HVID, and you look in the mailbox and you have a brand new Bitorque GP lens in the mail in just a couple days. But it's actually something that's been studied, and we're noticing that this process of fitting GP lenses is giving improved initial patient satisfaction. It improves the overall fitting process in the eyes of the patient, but really in the practitioner, it makes things a lot easier. But it's just really practical method for a lot of different reasons, especially our pediatric patients. But when it comes to this kind of reducing doctor-patient interaction in our office, it's an unbelievable option. But as you know, with regards to these fits, if it's a regular cornea, it's okay. It's very easy to order lenses empirically. But GP lenses have traditionally been pretty difficult for manufacturers to develop ways to be able to order them empirically with irregular corneas. But this is changing now. Our technology has created options for doctors to fit scleral lenses now empirically, and it's come a very long way. And in some instances or some respects, it's actually giving us much better outcomes. So again, studies around this empirical fitting of scleral lenses have shown to be extremely effective, not only in your results, but going back to our overall conversation, it's possibly a safer method for contact lens fitting as opposed to the diagnostic lenses that we're traditionally accustomed to. When it comes to empirical fitting of scleral lenses, there's really two methods. You have your impression-based techniques and you have your eye profilimetry techniques. When it comes to the impression techniques, basically you can see on the image above, an impression is taken of the eye. Afterwards, a 3D scan provides information for a custom lathe to get a lens that's highly specific to what is being requested by that mold that you created, and it matches precisely the curvature of the ocular surface. When we talk about the other designs where we're not using molds, there's technology that's actually scanning the front surface. Some technology is able to go out about 22 millimeters and they measure the sagittal height. They can assess the presence of toricity and account for those things. There's other instruments or software that's available that go to a maximum of 18 millimeters horizontally and 17 millimeters vertically, again, with the ability to incorporate scleral toricity, coming up with a design that's specifically catered or tailored to what the patient needs. Now, both of these products measure the eye in primary gaze, but there's some that actually can alter their positions in superior and inferior. So again, a lot of options here with regards to getting an empirically designed contact lens. So we talk about changes in the fitting process. What about the insertion and removal training? Has that been modified in your offices in light of the changes around COVID-19? So when it comes to contact lens protocols in the office, you really want to maintain a clean area by wiping the surfaces down and really kind of going back to what we previously talked about and the products that we use for cleaning, making sure we're being very specific with what we're using and how frequently we're cleaning those areas. The contact lens area really needs to be socially distances from other activities in the office. Now, due to the fact that we want to limit time in the training, you may want to consider what we've done in our office is provide patients an opportunity to watch a video before starting the procedure. In one of our contact lens rooms, we actually have a television screen that's displayed where we have pre-recorded videos, or as you can see in this image, we'll have those videos on our website where a patient can just log into and they can actually watch it on the phone. This greatly reduces the time that the trainee needs to be in the room, and so that when the trainee gets started, they have a nice little background to get started with. Now, when it comes to the trainee actually interacting with the patient, we do realize that a contact lens training process is one where people are in very close proximity. So I definitely encourage, or I require that my technicians wear a mask. They are frequently washing their hands, and a face shield or goggles can be used. In my office, I leave it up to the discretion of the technician if they want to wear that. But again, if they are training a patient, we have to understand that you are really bringing yourself very close, and we want to be clear to use some of these products to make sure that we're protecting both the patient and the technician. So patients should always be masked, and when we get to a point where we feel the patient it has an adequate handle on the contact lenses, putting them in and taking them out. We really want to take the time to go over this with the patient, because as we noted very early in this lecture, a patient will have a safe experience with contact lenses if they're doing what they're instructed to do as far as hand washing, disposal, replacement, and these things you really want to spend time going over with your patient. We have brochures in our office that help the patients kind of get have something tangible to take home, so they can be reminded about the different things they can and they cannot do with their contact lenses. Again, the replacement schedule emphasize avoiding water on the lenses and encouraging recycling of lens materials, cases, and solutions. So all of these things that we've always educated our patients are, we're just taking an extra step in light of our trying our best to decrease virus transmission. So with regards to our follow-up care, the final piece of our contact lens fitting, how have things changed? We talk about being able to provide as many follow-ups as clinically necessary, but we want to limit the patient flow in the office, and that's where we have these virtual online platforms that have been extremely helpful, and we've used them in our office. Depending on what the follow-up looks like, you can have your technician or one of the doctors follow up with the patient to help facilitate follow-ups and ensure that we have a good final prescription. And just to kind of summarize things, I really wanted to just talk about your practice. This is a picture of our practice, what we should be doing post-COVID, and again, doing things to educate our patients that we are aligned with the recommendations of professionals, and we're doing things that are healthy, and that when they come to our offices, that they're secure. And you can do this by increasing the communication, whether it's on your website or your social media. Make sure that you explain to patients that you're open for business, and that when they come, what they're going to have to do to maintain compliance, whether it's masks or temperature readings. We definitely want to continue to reach out to our patients with that whole conversation with regards to essential and routine vision care, as we're starting to normalize our offices, making sure that we're reaching out to patients and get them back in our practices. If telehealth is something that is necessary, we can definitely utilize. And take all that into consideration as you're booking your patients. You want to let patients know what's going on and why you're spreading out patients, but give them the opportunity, if you have, to utilize your telehealth platforms. Because we have to remember, we have all sorts of complex patients. We're all contact lens fitters here, but a lot of us are managing diabetic retinopathy, macular degeneration, glaucoma, myopia management. So we want to get these patients back into our practices, but comfortably, so that they feel secure. And you also want to think about your staff, because you don't want the staff to have any unnecessary burdens of stress. So you definitely want to communicate with them and be sure that they're comfortable with the decisions and the protocols that are being made, so that everyone can feel comfortable coming back to the office. And you can do that by ensuring a positive work environment, being very vocal about communication, about decisions that are being made in the office and why those decisions are being made, again, to protect the staff and the patients. So in summary, we started off with this image, and we talked about how this virus has such a huge impact on our lives and our professions. But we've learned that there's no evidence to suggest that contact lenses wearers who are asymptomatic need to cease contact lens wear due to increased risk of developing COVID. We learned that there's no evidence to suggest that wearing prescription spectacles provides any additional protection against COVID or coronavirus 2. We've learned that we have a new level of responsibility and our messaging to our patients and to the public, and that it's extremely important that we're clear in how we describe things. We learned that adjusting office protocols are helpful in reducing virus transmission. And finally, we talked about new options for contact lens fitting that not only decrease virus transmission, but they actually are good as far as moving the process along quicker, and in some studies show actually even better results. So There's still room for investigations. Further study is required, I would say, with regards to materials and disinfection systems. But as we've learned with everything else, this is an ever-evolving virus, and things are going to continue to change. If you listen to this lecture in a couple months, some of these things may even be outdated. But it's up to us to keep educating ourselves on this rapidly evolving virus so we can keep our patients and our staffs safe. Thank you.